Next, let's take a look at the clinical manifestations of tuberculosis. We have pulmonary tuberculosis and extrapulmonary tuberculosis. Sometimes we have both pulmonary tuberculosis and extrapulmonary tuberculosis. They can share the same symptoms. Usually, at the early course of disease, symptoms can be non-specific and insidious. Patient may have diurnal fever and night sweat. Most of them may have weight loss, anorexia, general malaise, and weakness. About 90% of them have cough. Usually, this type of cough is non-productive and limited to morning. Some may have purulent sputum and even blood streaking. About 20 to 30% of patients may have coughing blood or hemoptysis. Some patients, if they have pleural or subpleural involvement, they may have pleuritic chest pain. If the disease is rather extensive, patient may have dyspnea. The most severe type of tuberculosis may have the symptoms like ARDS. What about the signs of tuberculosis? Most of them are undetectable, are of limited use, but after coughing, patient may have rouse during inspiration. If the patient have partial bronchial obstruction, we may hear rhonchi. With large cavities, patient may have amphoric breath sounds. Usually, patients with tuberculosis, they are paler in skin. Some of them, especially those with chronic fibrosis tuberculosis, they may have finger clubbing. Pulmonary tuberculosis, we have already learned we may have primary TB and post-primary TB. They can be a little different in clinical manifestation. For primary disease, usually they are asymptomatic, which means they have almost no symptoms. Some may have fever or occasionally pleuritic chest pain. Usually, patients' middle or lower lung joints are involved. Some may have Gone complex. What is Gone complex? Gone complex consists of peripheral lesion and transient hilar or paratracheal lymphadenopathy. Peripheral lesion usually form after initial infection. Patient may have or do not have pleural reaction, but usually you can find thickening of pleura. Gone complex is visible on standard chest radiography, and this chest X-ray on the left side clearly show the peripheral lesion as indicated by the arrowhead, and the enlarged lymph nodes or lymphadenopathy indicated by the arrow. On the right side, we can see the CT scan of the same patient. The white arrow shows the enlarged hilar lymph node. And with primary disease, we can also see some skin or mucous membrane involvement, like erythema nodosa on the legs and flextanular conjunctivitis. These two types of skin or mucous membrane involvement are not that common, but still we can see some of them on our patients. This is the picture of skin lesion on patients with primary tuberculosis. You can see very extensive damage. And this is also a picture of erythema nodosa. Erythema nodosa on patients' legs. And also the same lesion, quite extensive. And this is the conjunctivitis. For post-primary disease or adult type disease, they are relatively localized, usually happen in the apical or posterior segments of the upper lobe or superior segments of the lower lobes. These positions have the lowest movement or blood flow or lymph flow, which makes these areas vulnerable to post-primary tuberculosis. And the lesions have very broad spectrum, from small infiltration to extensive cavitary disease. In post-primary disease patients, cavity formation is quite common. And we can also see bronchogenic spread and satellite lesions in these type of patients. Casein pneumonia is also frequently seen in post-primary TB patients. If these patients are not treated properly, galloping assumption can also be seen. But some of post-primary TB patients can spontaneously remit. Some patients may have a chronic, progressively debilitating course. This chest X-ray shows a cavity in the upper lobe of patient. We can see the air fluid level. And this chest X-ray shows a big cavity in the right upper lobe of this patient. Also, we can see very extensive infiltrations in the same lobe. Some small cavities can be seen in this patient's left lower lobe, and we can see satellite lesions surrounding these patients' cavities. Actually, we can also see lesions in patients' right upper lobe. This CT scan shows a thin-walled cavity in patient's right upper lobe, and we can also see the satellite lesions. Some small cavities in patient's left lower lobe, and also we can see satellite lesions. Actually, some of the lesions have the so-called tree in bud appearance, which suggests the bronchogenic spread of tuberculosis. These three pictures show the healing of a thin wall cavity in patient's right upper lobe. You can see the cavity gets smaller and smaller, leaving a fibrotic scar. Thank you for your time.